Okay, so question 5. How do you measure intraoperative astigmatism? So some people don't. Do you use like a Morley rule or concentric rings like the Maloney, air bubble, computerized if you're lucky?
Yes, absolutely. For me, really minimizing that post-op astigmatism is just comes down to measuring suture tension. So we do pay a lot of attention to having symmetric suture tension, and I suppose there are limits to our ability to detect differences, but we usually just sort of do a little just kind of plucking on each suture as it's placed, and at the end to make sure that there's, that within a certain range that the tensions are fairly close to each other. And again, I can't really, in a sophisticated way, tell you how close they would be, even if we feel like they're close, but at least we're making some attempt to make sure that the suture tensions are relatively close to one another. And then we'll use the air bubble. I think that picks up larger amounts of astigmatism that you could address at the time. But I think that it's because of healing, I think because of maybe positioning, the effect of the lids, and really knowing what the IOP is relative to where it would be baseline for the patient. I think there are just so many factors that come into influencing our impressions intraoperatively versus what we actually get, that I don't really spend a lot of time doing this. I'll look for major problems such as, 8, 10 diopters of astigmatism caused by very asymmetric suture tensions, or the air bubble showing, something that I think is at a higher level, that should be addressed at the time. But in general, I think that it's hard to get at smaller amounts on the order of 2 or 3 diopters, and then what that really means in the post-operative process, it's hard to know as well. So I guess one way of putting it from my standpoint is I don't spend a lot of time doing this. I feel like with post-operative suture adjustments and contact lenses, the patients will almost always get good vision. That might be a little bit nihilistic as an approach, because I think that if we could minimize it, we definitely should, because that would give the patient a better outcome. But at the same time, I don't really feel like I have a very reliable way of approaching that. So, so how about you? How do you?
Well, in the ideal world, but if you had a perfect epithelium at the end of your case, and you got a beautiful light reflex with the placido disc, you'd have some sort of computerized keratometry to allow you to adjust each suture individually. That would be great in the ideal world. If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.